Before diving into the topic, let us begin with a case scenario where two patients in their mid-60s present with a similar looking X-ray and they undergo a similar procedure, and we see that one patient is happy and gets discharged early while the other patient crips in pain, has delayed mobilization and prolonged hospital stay and gets discharged late. I'm pretty sure most of us must have we have seen such situations in our day-to-day practice, and after seeing this we start to wonder why this happens. So the answer here could be sarcopenia. So we came up with a study to find out, is sarcopenia a hype or does it really affect the outcome of spine surgeries? It was in 1980 when the term sarcopenia was first coined by Sir Erwin Rosenberg, which basically means impaired muscle function secondary to loss of skeletal muscle mass. There are n number of causative factors for sarcopenia, with the most common and the important ones being old age, impaired nutrition, lack of physical activity and hormonal causes. With the prevalence of more than 50% in those aged above 60 years, sarcopenia is a known and an important risk factor for repeated falls, fractures, disability, prolonged hospitalization, and increased post-operative morbidity and mortality. An initiative by the named European Working Group on Sarcopenia in older people, they first met in 2010 and they defined sarcopenia as a muscle mass, based on the muscle mass. But it was as late as 2018 when they realized that muscle strength has more importance than muscle mass, and they redefined sarcopenia as a muscle disease. And it was first time that it was included in the ICD-10. The group gave a criteria where only low muscle strength was considered as probable sarcopenia, and along with that, if there was low muscle quality or quantity, then that would confirm the diagnosis of sarcopenia. And along with the above two, if there was low physical performance as well, then that would be labeled as a severe sarcopenia. Here are a few tests advised by the working group to assess the above parameters, where skeletal muscle strength can be assessed using handheld dynamometer and 30-second chest hand test. Skeletal muscle quality and quantity can be assessed using MRI or CT scan, bioelectric impedance analysis, and DEXA scan. And physical performance can be assessed using gait speed, short physical performance battery test, and timed up and go test. The objective of a study was to prospectively evaluate for any correlation between sarcopenia and surgical outcome in patients who are being operated for lumbar spine pathology, for which we chose a prospective study design consisting of 114 patients who were categorized into 5 groups based on the age and were studied up for a duration of at least 3 months from the date of surgery. The outcomes were measured using grip strength using a standard handheld dynamometer, 30-second chest hand test, psoas muscle index, which was calculated on preoperative MRI at the level of L3 pedicle and was standardized to the height and compared it with the normal reference of Indian population. The ODI scores were calculated preoperatively and again at 2 weeks and 3 months postoperatively. And it was important to note that a difference of 12.8% was required to call it as a significant difference. Any perioperative complications were noted and were graded based on Lindo-Clavin classification. That based on the time to mobilize, patient was categorized as early ambulators when they were mobilized within 24 hours of surgery, as intermediate when mobilized between 24 to 72 hours, and delayed when mobilized beyond 72 hours. Based on the length of hospital stay, it was considered as optimal when it was between 0 to 3 days, delayed when it was between 4 to 7 days, and extended when it was beyond 7 days. Any 90-day readmission rates and mortality, if any, were recorded. Here is a flowchart showing the summary of the methodology, where patients selected for lumbar spine surgery beyond 40 years of age were assessed for sarcopenia using grip strength for upper limb and chest hand test for lower limb. And we had 2 groups, one with probable sarcopenia and another with no sarcopenia. Sarcopenia was confirmed using by calculating psoas muscle index on preoperative MRI at the level of L3. And based on that, we had 2 groups, one with confirmed sarcopenia and another with no sarcopenia. And the postoperative outcome in these 2 groups was calculated using the below mentioned variables. Moving on to results, it was interesting to note that in the age group of 40 to 50 years, there was no significant difference in the postoperative outcome between the sarcopenic and non-sarcopenic group. But there was significant improvement in the statistical significance of change in ODI scores in non-sarcopenic group, which was much better than the sarcopenic group. Beyond the age of 50 years, we started noticing some significant difference in the postoperative outcome between the 2 groups, with sarcopenic patients having higher CD scores, more patients with delayed mobilization and prolonged hospital stay. The similar trend continued in 60 to 70 year age group as well, with sarcopenic patients having poor post-op outcome with more higher CD scores, delayed mobilization, more patients with longer hospital stay, and 1 patient required a readmission within 90 days. In the 70 to 80 year age group also, the same trend was noticed, with sarcopenic patients having poor post-operative outcome as compared to non-sarcopenics, with higher CD scores, more patients with delayed mobilization and prolonged hospital stay. There were 2 patients who required readmission within 90 days. In the age group above 80 years, it was interesting to note that all our female patients were found to be sarcopenic with poor postoperative outcome. There were two mortalities in the entire study, and both the patients were found to be sarcopenic. So here comes the big question: why should we care about sarcopenia? As we know that life expectancy around the world has been increasing, and this has led to increase in the elderly population. And we know that sarcopenia is a known and an important risk factor for repeated falls, fractures and disability, and this will burden the patient economically, socially and personally. In studies, it was seen that more than 40% of the patients undergoing orthopedic surgery were found to be sarcopenic, with 3 times higher number of complications and longer hospital stay. All is not lost. We know that sarcopenia is a treatable condition which requires a combination of pharmacotherapy, nutrition and assisted physical therapy. With newer modalities of treatment coming up every year like gene therapy and regenerative medicine, it gives us an upper hand to better predict and be prepared for the poor outcomes. I would like to conclude by saying that sarcopenia is not a hype and we need to take it seriously. Thank you.